Okay, so this is Chapter 8, Caring for the Woman Experiencing Complications from Labor and Birth. We're going to start on page 243. Alright, dystocia. This is a term for long, difficult, or abnormal labor. Okay? Poorly defined as poor labor progression, uterine contractions, like something's going wrong. It's just not going as we planned. So maybe a breech baby, maybe a cervix is swelling, but something's going on. Okay? So make sure you understand that term. Hypertonic labor is when we have strong contractions that are not effectively changing the cervix. Okay, it may just be cervical changes back to back to back. This is an example over here on the strip, hypertonic. This is in your book as well. The top one is normal. The middle one is hypertonic, where there's really no resting period, and they can even be closer than this strip is showing. And then we have hypotonic, which are they're spaced too far out. Okay. Box 8.1 shows you the risk factors for uterine dystocia, and there are the strips again. All right, on page 245, trial of labor, TOL. This is when we actually just see how she's going to do with a vaginal birth. Remember how we do like the contraction stress test or the non-stress test? This is just seeing how she tolerates the trial of labor. Amniotomy, or AROM. This is when the health provider breaks the water. So artificial rupture of membranes. Okay, amniotomy means artificial rupture of membranes. Remember I talked about AROM and SROM. SROM is spontaneous rupture membranes where the water breaks on its own, but amniotomy is the artificial rupture of membranes. You'll see this on report sheets like AROM or SROM at and then a time. Okay? Winking lollipop. So you need to know what you need to do when this happens. Okay? So what are we doing when the provider goes in and breaks the water? Okay? Winking lollipop. We are to monitor the fetal heart rate. We're looking for any complications, cord compression, and then we're also looking for umbilical cord prolapse. And that's when the cord slips past the presenting part, so the head, hopefully, and it ends up in the vaginal vault. So this can be a bad, bad thing. We'll talk more about this when we get to that section, but we're looking for all of this when we have the amniotomy. Okay? Induction of labor. So there's lots of reasons why we induce labor. It may be post-term, like she just has not gone into labor. Maybe reasons like preeclampsia or gestational hypertension, which are not the same thing. We'll talk more about that. Diabetes mellitus, some type of chronic illness, fetal demise, chorioamnitis, which is an infection in the chorion membrane of the uterus, premature rupture of membranes, so the water's been broken too long, placental abruption, fetal compromise, something's going wrong. Oligohydramnios is a term where there's not a lot of amniotic fluid. Polyhydramnios is the other term that means there's too much fluid, or IUGR, or fetal growth restriction. IUGR is intrauterine growth restriction. And preeclampsia. This is an amni hook. So I'll show you one of these in class. This is what they use to break the water. It's just like a little piece of plastic, and it has a little sharp tip on the end of it. And you use that to break the balloon, to break that amniotic membrane. Okay? There's a Bishop score that are sometimes charted, and this is just giving us a score on what's going on with the labor. The highest possible score is 13. Okay? The lowest possible score is a 0. Table 8.2 is talking about some cervical ripening agents. These are used all the time. There's one called Cytotec, which is a little tiny pill. We place it without using any type of lubricant because it will not dissolve into lubricant. So we place it right outside of the cervix. Sometimes it's hard to find if we have to go back and retrieve it, but it's usually a quarter of a 100 microgram tablet, and that's the initial dose. We watch the strip, watch the mom, see how she tolerates it, and sometimes we have to retrieve it if it's too close to the cervix and she has some hypertonic contractions, okay, which remember are these over here, all right? And then we also use something called a Cervidil. This is another ripening agent that dissolves, but it's on a string, so it's very easy to retrieve if we need to retrieve that, okay? There's the Amni hook, the Bishop score, all right? So let's go flip on over to page 249. 248. Let's look at 248. So mechanical methods. We have another mechanism that's fairly new in the last 10 years or so called a CRB, which is a cervical ripening balloon. And what they do is take a like a red rubber catheter, and they have some that are designed specifically for inducing labor now, but you can use like a catheter, just a straight cath. You insert the balloon catheter into the cervical opening, okay, the cervical os, and you inflate it, okay. So you inflate it with, of course, saline fluids, okay. And what it does is cause that cervix to start dilating, hopefully. It is painful, and it sounds painful. It is painful, but you just start stretching it, and you can add more fluid to it as you need to, okay? So that's one way. And then the oxytocin, this is how we induce labor as well. We start the oxytocin or Pitocin at 2 milliunits a minute, and we increase it every 30 minutes or so with a max dose of 20 milliunits, okay? There is a high dose where you can start at 4 and increase by 4, but it's usually by 2. This is, like I said, one of your drugs on your drug template, so you need to know that drug, okay? All right, so let's talk a little bit more about it. Signs of hyperstimulation include the following. So you need to know this as a wink and lollipop, okay? Know what is deemed hyperstimulation, okay? That's uterine contractions that are last greater than 90 seconds and occur more frequently than 2 minutes. And then uterine resting tone that's greater than 20 to 25 millimeters of mercury with a peak pressure of 80 millimeters of mercury. And that's how far they go up on the strip. So over here, if they are just like really far, this, especially if it's an external monitor, it's not 100% accurate. So that's why we like those IUPCs, the intrauterine pressure catheter, because it will accurately tell you the millimeters of mercury for the contractions. Clinical judgment alert. So just make sure you understand the contraindications on the use of oxytocin. Read through these and understand this clinical judgment alert. Alright, so on page 251, there are some, you read through all this, but there's some assisted operative or vaginal delivery devices that the physicians use. These are forceps, different types of forceps. Piper forceps, very common. The Simpson forcep is another common one, but they do use these still. They can cause some traumatic injury to the cephalic portion of the fetal head, cephalic head of the fetus. They do use those. They also use some vacuum assisted birth. And this is where we use what we call a vacuum device or a kiwi, and I'll show you these in class as well. This is a kiwi, and I'll bring one of these in the vacuum and show you. But this is a handheld when it's not connected to suction, but you just pump this up until it gets to this green mark, and you, with a contraction, and only with a contraction, do you pull, okay? So the physician would pull with the vacuum using this. It will make a little hematoma on the baby's head that will absorb. It didn't cause any lifelong damage. It's just a day or two, and that fluid will absorb, okay? So let's look at labs. Some maternal conditions that can complicate childbirth. Preeclampsia is one of them. Preeclampsia is high blood pressure, protein in the urine. You have a lot of different things that happen. So just make sure you read through these labs, understand those. Cardiac disease, diabetes mellitus. And we know diabetes mellitus can cause LGA. LGA is large for gestational age. So if you have a pregnant woman that has diabetes or gestational diabetes, then it can cause the baby to be very large. Then we have a complication on top of that that's called CPD, cephalopelvic disproportion. Okay, so cephalopelvic disproportion is when the pelvis of the mom is too small for the baby's head to come through. Okay, a lot of times this happens with these bigger babies, and they end up having to have a C-section. Procedures to check for DTRs and clonus. This is one of the things that preeclampsia can cause. Preeclampsia is before a seizure. Okay. Eclampsia is with like an active seizure. You're eclamptic. So you're not having a seizure if you're preeclamptic. We're trying to prevent you from having a seizure. So nursing care, you're checking the blood pressure, you're checking the weight because they're going to have a lot of fluid retention, medication administration, renal balance. So we're doing renal labs, pulmonary status, neurological status, any headaches, blurred vision, dizziness, epigastric pain, okay? We're checking the DTRs. So all of these things happen with preeclampsia. We'll talk more about that. Preterm labor. This occurs after 20 weeks and before 37 weeks, okay? That's considered preterm. So after 20 weeks and before 37 weeks. You need to know this, okay? Then we have some medications. So if we have somebody that's in preterm labor, we can give these some medications to stop this, okay? One is mag sulfate. So we use mag sulfate for two different reasons. For preterm labor, to slow down the contractions, hopefully to stop them. And we also use mag sulfate for preeclampsia, to keep her from having a seizure, okay? So our loading dose is usually 4 or could be 6, and then it's usually 4 loading dose and 2 maintenance dose, but it can be 4 to 6 or 1 to 4 according to the situation, okay? But for Wink and Lollipop, you need to know what to observe, okay? So if she's on magnesium sulfate, you are watching the respiratory rate, okay? You're watching for pulmonary edema, you're watching for respiratory rate, and what can be signs of pulmonary edema. So this can be trouble breathing, some congestion sounding, some swelling, so we are watching for that. And we can also give terbutaline, breathine, and this can make her feel like she's just taking a whole big pile of steroids. And then we actually do give a steroid called betamethasone, okay? Betamethasone is given for fetal lung maturity. This is given for somebody in preterm labor, okay? So Wink and Lollipop. If we have somebody going into preterm labor that's early, we're going to give them a dose of betamethasone, and that is to help the fetal lungs develop, okay? So surfactant, which is a glue that keeps the alveoli open, we're going to talk about that, but that keeps that alveoli open and helps those lungs, fetal lungs, to mature, okay? All right, 258 or 257. Let's talk about this real quick. This is a version, okay? It's called version. It's turning the baby, okay? So where you can either internally or externally turn the fetus, okay? So if they're laying transverse, we're trying to get them cephalic, which is head down. We can. This baby is being born breech, so. And then we have the external cephalic where we turn it on the outside. Shoulder dystocia. Remember, dystocia is what? Trouble in labor, right? So this occurs 0.2 to 3% of all births. We have a maneuver called the McRoberts maneuver. Wink and lollipop. You need to know all the things about McRoberts, okay? It's where you attempt to turn that baby where the shoulders can come out. So shoulder dystocia is where the shoulders are having trouble passing through the pelvic inlet, okay? You're going to monitor the movement of the fetus when it actually is born, after the baby's born. So wink and lollipop, you're going to know this information, okay? I know this is a lot, but you need to know it. So you're monitoring for movement of the infant's upper extremities after delivery. The mom's going to be crowning the perineum, retracting, protruding out. It's a turtle sign where the head's coming out, but it's just not staying out, okay? And when we see this, it's usually indicative of shoulder dystocia, okay? It can be a reason for the mom to have an extension of an episiotomy or a tear. Blood loss, even from uterine atony, a rupture can happen. All of this is a wink and lollipop, there, guys, okay? And then some more. She's placed in a lithotomy, and there's pressure placed on her symphysis pubis. So lithotomy means legs are back, okay? So this picture here, okay? So it's knee to chest. Usually there's 3 or 4 nurses in the room, or a family member holding one leg back, another nurse holding another leg back, and then you're opening up that pelvis, placing symphysis pubis pressure on the symphysis pubis, suprapubic pressure, and hopefully the baby will be born, okay? Zambanelli is another term, and this is when we're placing the head back because we cannot get the baby out, okay? So Zambanelli is a term that we're placing the head back into the uterus to perform a stat C-section, okay? The Woods maneuver. This is a corkscrew remover, okay? This can be performed. It's a rotating maneuver when the physician attempts to rotate the baby's head in order to get the baby out. Cephalopelvic disproportion, just what we were talking about, where the head is bigger than the pelvis, okay? Kind of makes sense, right? Cephala is head, pelvic, pelvis, disproportion, okay? All right, nuchal cord. Let's talk about this. It's on page 261. All right, a nuchal cord is when the cord is wrapped around the infant's neck, okay? There are true knots in there. That happens up to 29% of births, and that's not a good thing. A lot of times that's the reason for fetal demise. but the cord, hopefully, if it is on there, it's loose. I have 3 kids, and this happened with all 3 of mine, but they were okay. We'll talk about that in class too. Meconium. Meconium is a bowel movement that happens in utero, meconium stained fluid actually. So if you see that, that's something, remember we note when we talked about the amniotic fluid, we're noting the color, the odor, and the amount, right? Oligohydramnios is when there's not enough amniotic fluid. Hydramnios is the normal amount, but then there's polyhydramnios. This is greater than 2 liters, okay? And then chorioamnitis. Chorioamnitis is the infection that happens in the chorion, the membrane of the uterus, okay? If you've ever smelled C. diff, it's kind of right up there with it. It's a very foul smell of the amniotic fluid. You won't forget it. You just, like, as a labor and delivery nurse, you know, walking in, you can smell the chorioamnitis. She usually runs a fever, so we're giving her some ampicillin and gentamicin, but this can cause a sick mama and a sick baby, okay? So you need to know this wink and lollipop right here. It happens more than we like. So this is why it's so important to get vital signs during labor, okay? Every 2 to 4 hours, we're checking temps, we're checking blood pressures. She spikes a temp, then we are starting to investigate, okay? So let's see. So know these reasons right here, winks and lollipops, okay? All right, so intrapartal hemorrhage, complications with the placenta. So what we do what's called EBL, estimated blood loss, or QBL, quantitative blood loss, and this is where we measure the amount of blood that comes postpartum. So we're measuring, we're weighing pads, like Chuck's pads, Perry pads. We're weighing everything that she's losing to make sure that she's not losing too much blood. In a vaginal delivery, she can lose up to 500 milliliters of blood, and for a C-section, she can lose up to 1,000 milliliters of blood and still be okay. Placenta previa occurs when there's a, and this is just the cord prolapse. We'll talk about that in just a minute. Let's see. Yep. So placenta previa is happens when there's a portion of the placenta that is kind of low-lying. We'll get into a lot more detail about that in just a second, but a big thing you need to know is the biggest reason placenta abruptions happen, and this is when they just actually starts detaching, but the biggest reason it happens is cocaine use, okay? So biggest reason associated with vasoconstriction, biggest reason for placental abruption is cocaine use. We'll talk more about that, okay? There's a case study on page 263 you need to do to put it all together. Make sure you do that when you're reading. And then DIC. So disseminated intravascular coagulation. Okay, so remember us talking about this in previous chapters, the HELP and DIC. We'll talk more about this, but this is when they overproduce the clots, okay? Overproduction of clots, they're bleeding from every orifice, okay? These are the different labs, D-dimers, PT, PTTs, fibrinogen, all of these are done to check for this, okay? Then there's some drugs that we use, okay? Heparin, antithrombins, because it's overproducing of the clots, okay? Umbilical cord prolapse. So, what we were talking about a while ago. This is emergency. Happens 2 out of every 1,000 births. Very dangerous. This has happened to me. I went in to check a patient and felt cord. So, what did I do? You leave your hand in the vaginal vault and don't push the cord back in, but you push up the fetus. You push up the baby's head off of the cord to get the pressure off of the cord, okay? Huge winking lollipop, all right? So, to relieve cord pressure, the examiner with a sterile glove lifts the presenting part off of the cord, okay? You leave your hand in place. So I called for help, left my hand in place. We wheeled back for a stat C-section. They threw the blue drapes over me. I was on the bed riding the hall with the patient, riding the hallway, okay? Back to the C-section OR. They cut her, could see my hand when they pulled the baby out. So, very scary situation, but you have to know what to do, okay? But number one thing that you're going to do, please listen, wink and lollipop, is you're relieving the pressure off the presenting part, okay? If the cord is protruding from the vagina, what are you going to do? You're not going to place it back in, okay? Do not place the cord back in. You're going to wrap it in warm, sterile, saline compressed gauze, okay? So if it's protruding, you're going to get somebody in there with you, because what are you doing? You're holding the head off the presenting part, right? So they're going to bring you some warm saline soaked gauze, and you're wrapping that cord that's outside the vaginal vault in that gauze until we can get the baby out, okay? We're placing her in Trendelenburg position, upward pressure, getting her head down, pelvis up, and going straight to the back for a stat C-section, okay? Please understand, huge winks and lollipops right here, okay? You need to know those. All right, so focus on safety. We're not flipping her over, we're just getting her Trendelenburg if we can, okay? You can flip her, but whatever works the best. All right, focus on safety. So make sure that you are familiar with everything in here, okay? Anaphylactoid syndrome on page 269. This is amniotic fluid embolism, formerly known as, okay? Anaphylactoid syndrome of pregnancy. This is when the amniotic fluid gets into the bloodstream, into the blood vessels, and it causes an embolism, okay? It does happen in 1 to 10,000 or 1 to 100,000 births. Not very common, but it does happen, and it can be fatal. Usually is fatal. All right, on page 270. We're going to look at the what to say. Communicating concerns. So, when you're talking to your patient, especially in times of a crisis, right? Like the stat C-section that was just going on with the prolapse cord, make sure that you validate and reword their concerns, okay? Make sure that you're listening to your client, okay? Wink and lollipop. Listen to your patient, all right? Listen to them. Make sure you're rewording and validating what their concerns are. Okay? All right, cesarean births. Let's talk about this. So maternal risk factors associated with this, there's a lot of those. Okay? So here's a few right here. CPD, cephalopelvic disproportion, of course the prolapse, hypertensive disorders, HIV, active genital herpes, several reasons. Okay, so just be familiar with those. A1, which is our Association of Women's Health and Obstetric and Neonatal Nurses Association. They support the need to learn more about the nature of elective C-sections. Okay, it's not ideal, but they are researching it. A lot of people just want a C-section because they don't want to face the pain of a vaginal delivery. But when you cut through 7 layers of abdominal tissue, you don't understand pain until that happens. So if you've had a C-section, you know what I'm talking about. But vaginal delivery, I would like to say that's the way to go, because yeah, you might tear a little bit or a lot like I did, but it's nothing like being cut with 7 layers of tissue. So, but some people do elect to do it. I have worked with actually an OBGYN that had an elective C-section because she wanted to save her vaginal fascia. So, to each his own. All right. Read about this nursing impact for surgical adhesions from cesarean births. You know that can happen with any surgery, right? And then there's different types of cuts. Okay, so we like to use the low transverse now, which is the bikini line. Vertical classic incisions. A lot of this happens out of country or I guess in other parts of the world. So, but once a mom is cut one way, usually the doctor cuts the same way every time. So if she's had a classic, then they're going to go back with the classic. Okay. But we like the low transverse or the bikini incision. Okay. I'll show you this video in class. This is an Alexis, what we use for cesareans. It's a really cool retractor, and I'll show you this in class. All right. VBACs. So let's talk about what is a VBAC. It's a vaginal birth after cesarean. So hospitals have to be licensed and having their policy to do VBACs. Several hospitals I've worked in have done it, and then they take it away according to their lawyers. Okay, it can be dangerous because the uterus can rupture, but they still do it in some hospitals. So just know that VBAC, what that term is, it's vaginal birth after cesarean. Okay. And this is a cesarean, obviously. Box 8.5, there's criteria. Just be familiar with this criteria here. And then perinatal loss. This is calcifications on a post-term placenta. But perinatal loss, this is one of the hardest parts about being a labor and delivery nurse, of course. It's when a neonatal death occurs. Stillbirth is after 20 weeks. Spontaneous abortion is before 20 weeks. Okay, so just know that term. Fetal demise is what we call it. And that is the end of Chapter 8 and the end of Module 2.